Good evening. I am Brother Dr. Jeffrey Sterling, Surgeon General for Alpha Phi Alpha Fraternity Incorporated. I'd like to welcome you to tonight's SGI webinar. We're going to be talking about organ transplantation, and this may be a somber topic, but we really want you to think about this as you may have family members that are involved. On behalf of Brother General President Willis Lonsdale III, I'd like to welcome you again tonight. And I just want to tee up this fantastic panel by just pointing out something that you'll be hearing several times in different ways over the course of the evening. Black Americans actually have it bad. We face disparities in all things healthcare, but this is yet another example of that. You probably would assume, but may not have known, that Black Americans are less likely than the general population, and particularly white Americans, to be identified when it's reasonable to do so as a transplant candidate. We're less likely to be referred for an evaluation of such, or to be put on the transplant waiting list to receive a kidney transplant when it's indicated, to even receive a high quality kidney transplant. And we also have a poor survival of the transplant itself. So how do we get past that? Well, that's what this conversation tonight is going to be about, because we want you to have an awareness of this and know when to enter the arena and considerations for these things as early as possible, because that'll give you the best possible chance of doing well. We welcome back as tonight's moderator, Alpha Phi Alpha's Deputy Surgeon General for Family Health, Brother Dr. Victor Narcisse III is a spring 1990 initiate of the Rho Iota chapter of Alpha, and he's currently active in Alpha Eta Lambda chapter. He practices at the Houston Methodist Hospital as the Associate Division Head of Hospital Medicine, and he is the Director of Clinical Research in the Division of Hospital Medicine. Brother Dr. Narcisse is board certified in internal medicine and in geriatric medicine, and he is a fellow of the American College of Physicians and the Society of Hospital Medicine. Brother Narcisse, have a great show. I will see you again at the end.
Thank you so much. I appreciate the introduction as always. I'd like to introduce the panel this evening. The first person I'd like to bring up is Brother Victor Lewis. Brother Lewis is a 1984 initiate of the Theta chapter in Chicago, Illinois. He works in IT, is married with 5 children, and lives in Tennessee. He's coming to us tonight because of his experience with chronic kidney failure and dialysis. He reached out to us and asked if we could increase awareness around this point, hoping that this would benefit all of the transplant waitlist community. And we wanted to bring him to the fore and tell a little bit about his story. We'll bring him back tonight, a little bit later to discuss his experience. Brother Dr. Robert Leggington is from Beaumont, Texas, trained at Prairie View A&M University, biology, went to UTMB for medical school, was a resident at Baylor College of Medicine in internal medicine, and did nephrology there as well. He works in private practice in nephrology in the Houston area, has a lot of experience with transplantation. He's been working in the space since 2005, and he's a member of the medical staff at my Houston Methodist Hospital. Next, I'd like to introduce Senator Brother Boris Miles, who is the Texas Senator for District 13 since 2016. He previously served 4 terms in the Texas House of Representatives, successful businessman and developer, owns one of the largest insurance agencies in Texas, and a commercial developer. He trained at Sam Houston State University and has done a great deal of work in the community. Has been named star of the legislative session by the Texas Classroom Teachers, champion of women's health by Planned Parenthood, works with urban agriculture leader by Texas A&M AgriLife Extension. He's developed programs in HIV, adopted by the CDC, given his time to Urban League, Houston Sickle Cell Association. I could go on and on and on. We won't have any time to talk about organ transplantation if we just keep talking about all these folks. Brother Dr. Billy Gilbert is a nephrologist, also with the Renal Specialists of Houston. He's a graduate of Morehouse College and trained at UT Southwestern medical school in Dallas. He trained in internal medicine and nephrology at Baylor College of Medicine. Been honored by the America's Best Doctors as one of their top doctors. And he is a member of Wheeler Avenue Baptist Church here in Houston, and has been active in the community by so many ways. We may have one other panelist that joins us along the way, but we'd like to begin our talk on organ transplantation. I'd like to just ask Brother Gilbert, can you tell us about organs that get? I see. Brother Cotton has joined us. Brother Ronald Cotton, I apologize, I didn't get the spelling right on the flyer, is a native Houstonian, a graduate of DeBakey High School. He was the valedictorian, summa cum laude from University of Houston. He completed his residency and fellowship in surgery at Baylor College of Medicine, joined the faculty in 2015. He is with the Division of Abdominal Transplantation, primary surgeon for kidney and liver transplantation at the VA hospital in Houston, Texas, and is, in addition to all of that, the associate professor of surgery at Baylor College of Medicine and the program director in general surgery for Baylor College of Medicine, co-director of liver transplantation fellowship, surgical director of liver. You get the picture. These folks know what they're doing. They know their doctor. And it's my honor. I've watched many of these individuals grow in their practice of medicine. If you haven't seen a TED Talk recently, you should go check out the one that Brother Cotton is in. He's done a fabulous job. I'll bother Brother Cotton. Thank you for joining us. Tell us about organs that get transplanted, Brother Cotton.
Yes. Well, good evening, everybody. I'm very happy to be here, and please forgive my tardiness. So when we think about transplantation, you can think about it in terms of solid organs and non-solid organs, and we'll focus today on solid organs for transplantation. So believe it or not, most of the things in your body can be transplanted in terms of solid organs. So hearts can be transplanted, lungs can be transplanted, livers can be transplanted, small bowel can be transplanted, pancreata or pancreas can be transplanted, kidneys can be transplanted. In addition, skin can be transplanted. You can have bones that can be transplanted. You can have valves from hearts that can be transplanted. You can have corneas that can be transplanted. So most of the parts of our body can be recycled, so to speak, and be shared, and that gift of life can be passed along to someone else.
We've heard that there's so many people who are waiting for transplants. Brother Lewis, can you tell us a little bit about what life is like while waiting for a transplantation?
Well, it's not easy, to say the least, but you have to I guess it's not that easy, but you have to come to terms with the fact that you are on the transplant list. You have to come to the terms that this is where you are in life, and you have to accept it, really. You have to accept it in the whole point of your whole life, really. So when I came to the fact that my kidneys were failing, I had a hard time, accepting it, but I had to get around to it because I want to live. Okay, I have my kids are grown. I have a grandkid, and I want to live, and I want to be around to see my kids grow up, and I see my grandkids grow up. So it's not easy, especially when you're talking about kidney transplant. I do a peritoneal transplant every night while I'm sleeping, but there's a lot of supplies that I have to order every month, and there's a lot of coordination I have to take care of every day, every night. I have to plan. I have to plan my sleep every day. Um, I'm literally tied to a machine every night that cleans my kidneys out every night. That's the peritoneal dialysis. So I have to plan that. I have to plan the time I go to bed. I have to plan the night. And I have to plan the time when I get up. And I have to plan everything around that. And planning work and leisure and vacations, everything. So I have to plan my vacations a month or so in advance to deliver the supplies wherever I have to go if I want to go, or just take the supplies if possible. But there's a lot of planning that has to be in my life right now that before I was more like a spontaneous type of person. But and then you just have to accept the fact that, well, this is what's happening to your body. Um, Granted, I am 57 years old, and of course, your body's not going to live forever. But you have to. One of the things you have to do is you have to get used to it. Okay, I'm 57 years old. My kidneys have failed. I'm on the transplant list, and I'm waiting for that transplant, and I'm just going to wait for the transplant. And I refuse to. I refuse to become depressed about it. I refuse to let my emotions get the best of me, and I'm just going to go on and move on, and wait for this transplant to come through. One of these days, it will come through.
And kidney transplant is a different kind of a thing than several of the others because brothers Gilbert and Leggington are nephrologists who help take care of patients that are waiting for transplant. Brother
Yes.
Gilbert, can you just talk a little bit about what it's like to oversee a person who's on dialysis?
Absolutely. And first of all, thank you for inviting me on this webinar with these distinguished gentlemen up here. This is a subject that's really near and dear to me. As you mentioned, me and Dr. Leggington, we're nephrologists. So our job is to basically treat patients who have chronic kidney disease and kidney failure and treat dialysis patients. And many times we really form a strong bond with these dialysis patients. We're seeing them on dialysis every week. And so it is something that we have to do on a daily basis is try to talk to our patients about why they should get a kidney transplant and what it entails to get on the kidney transplant list. Unfortunately, some of our patients, and many of them African American, have heard lots of myths and things we're going to talk about later on about getting a kidney transplant, and so we have to do a little bit of convincing in some cases. As Brother Lewis just mentioned, being on dialysis is something that's a process that can take a lot out of you. So a lot of these patients are, they're afraid because they've been through so much up to this point. So I have to convince them and talk to them about the benefits of kidney transplant. The number one benefit being that patients who get kidney transplants live longer than patients on dialysis. So you have a significant survival benefit from getting a kidney transplant. The second thing is you have a better quality of life. So when I talk to my patients, I try to bring it home to them as, hey, that graduation that you wanted to go to, that trip you wanted to take, these things and the time you wanted to spend with your family, you'll be able to get a lot of that time back and spend that time if you get a kidney transplant. Also, some of the medications that you're taking on dialysis and some of the other risks that you have during dialysis, some of those will be alleviated by getting a transplant.
Brother Senator Miles, I'd love to hear your thoughts about how life changes after transplantation.
Well, brother, before Dr. Narcisse, before I go into how life changes after kidney, I feel remiss to say to my brother Lewis, uh, brother, I was on Dallas for 2.5 years, ran a business and state senator for the largest Senate district in the state of Texas during a 6-month session where we rose every morning for hearings at 8 o'clock. And I'm going to respectfully have to say to you, Brother Lewis, because I love you, brother, in the infamous words of our dear late brother, Adam Clayton Powell, baby, you got to keep your faith and keep your fight, okay? Because there's the sunshine on the other side. So I felt obligated to say that to my brother out of love and respect. Brother Narcisse, your question was, what is life after dialysis? Is that what your question was?
How does it change? What was life like before? What is it like after?
It's a new life. It's a new life, Brother Lewis. It's going back to what you know, and it's going back to, it gives you new energy, new strength, and you feel like you're just 20 years old again, and everything that you used to do, you can do it again, brother. And I do mean everything. Look at me good. I do mean everything. Okay? So I want you to understand that. You brothers understand what I'm saying.
Yes,
And matter of
salute.
fact, Lewis, you're gonna do it better. Okay? But I need you to hold on. It's a new breath of life. You cherish the moments that you spend now. You spend them more wisely, and you're more focused on the goals that you want to accomplish. From a health standpoint, man, I eat like a hog every day. I drink a lot of water. I try to get my rest, and I'm catching up on all the things that I didn't do before the kidney. And I was on the waiting list for 2.5 years, brother. My grandmother died. My mother is right now on dialysis. And Dr. Narcisse, I also have I have sickle cell, SC, the most dangerous sickle cell disease, along
Yes,
with the failure of kidney. So, brother, you just got to have hope, because let me tell you, it's a much greater later. If you can understand what I'm coming to you with, it's a greater later, and you just cherish and you appreciate the time that God has extended you. And you appreciate great doctors like Dr. Narcisse and Dr. Gilbert and Dr. Cotton, for all of them that I know personally. Dr. Lexington, I'm sorry we haven't had a chance to meet directly, but these brothers I know directly, and you cherish them and you understand, and you appreciate that you have good brothers that surround you and are there for you. But you got to keep your faith, Brother Lewis. You've got to keep the faith. You've got to keep your fight. And I
yes,
can assure you, man, it's better on the other side. Much
yes,
better.
yes. Well,
It'll keep you focused on things you want to accomplish.
that's the most important part right there. I mean,
That's it, brother.
you gotta keep. I refuse to be. I refuse to let this take me down.
If I could, Dr. Narcisse, if I could just give you an example of my days when I was in session for 6 to 8 months, okay? I'd wake up at 3 in the morning, go to dialysis when I was in Austin, because in Houston I had dialysis at home, which made it a little bit easier. It was I dedicated the bedroom to my house and had all the equipment there, but it made it a little easier. But when I was in session, okay, I literally had to go to a dialysis center. I'd get up at 3 in the morning after going through hearing all night long, go to dialysis, and we made arrangements so that I would be kind of isolated from the other people. And I had to have to give credit to my staff, Ms. Foster and Senator Crosley. They were there for me. I'd go in, I'd stay there in dialysis. Sometimes I wouldn't leave until 7:30, 8 o'clock. Go home, shower, try to get my medicine in, get my food into my body, and then go straight to the floor. Now, Brother Lewis, you know how tired you are when you get off that dialysis machine. Okay, I'd have to drag myself to that capital and deal with some of these demons that we deal with here in the great state of Texas. Okay, and I'm a double minority, have been for my entire public service life, 16 years, brother. And you don't know me, but I call a ball, and strike. And I let them know that I'm one of only 2 African American senators in this entire state. So we have to represent. So I can't you can't sit there and be quiet. You got to be active. You got to be engaged. But that strength, you'll get that strength all back to you once you've had that transplant, brother. And I heard you say a little bit earlier that some people are not in favor of transplant. I don't know who those people are, and I guarantee you one damn thing: none of them need a transplant. I guarantee you that none of them need a transplant, because if they did and they knew how important it was to sustain our life and our families and businesses and all the people that we come in contact and we touch and communicate with, they wouldn't say things, that they don't believe in that and transplant. Brother Cotton just told you, man, you can transplant this hair on my face right now if I wanted to. So have faith, and if you believe in your brothers, all these fine our doctors on this call, and our Surgeon General. Um, Look, man, we just got to hold on, bro. That's all. And if it's okay with you, I'm gonna ask Dr. Narcisse for your number, and we're gonna stay in touch. Is that okay with you, Brother Lewis?
Yes, that sure is. That'll be fine for me. Yes.
All right. I'd love to stay in touch with you.
Thank you.
Thank you so much, brothers. Since we know that 17 people die every day waiting for transplantation, is the experience different, Brother Cotton, for individuals who are in need of organs other than just kidneys?
So, well, one thing I want to say very, very quickly that I think Brother Senator Miles really highlighted quite eloquently is hope. And I tell patients, everybody who comes in to see me and talk about what a transplant looks like and talk about an operation, I talk about hope. That there's a hope that you can be restored, that your life can be made whole, and that there is more than end stage disease. In medical school, you learn that end stage disease is it. The next step is death. And then dealing with your mortality in a very real sense from a patient perspective, and then maybe even not feeling that way. But then, to see things changing, to see, your lifestyle changing, and to see that before your eyes, then to be offered the total opposite of that is extraordinary. Now, so I just want to, comment on that very quickly. But Dr. Narcisse, to answer your question, for each organ, there is a different what we call allocation system. So the allocation system aims towards giving organs to the patients that need them the most, and in general, giving the organs that are needed for particular patients at any given time. So we've talked a lot about kidneys today. I can speak, for instance, on the liver transplant waiting list. So patients who need a liver transplant have end-stage liver disease, also known as cirrhosis. And these are patients whose livers have failed, and it's usually manifest in a lot of different ways, including, their bellies get full of fluid, they turn yellow, they bleed easily, they get very confused. All those are examples of symptoms of end-stage liver disease. There are other indications for liver transplantation, but usually it's all leading to some very life-threatening disease process. So how do you give out organs? How do you pick who is the safest and gets the organs first? In the liver transplant world, we primarily use this thing called the MELD score, which is the model of end-stage liver disease, which looks at a series of lab values that goes into a formula, spits out a number that goes from 6 to 40. You cap it off at 40. People with that MELD score of 40 have the highest chance of dying from their liver disease within 3 months. They get the organ offers first, and it kind of goes in a row from there. So that's kind of how it works for liver transplantation. For kidney transplantation, something very similar. You're looking at what patients need basically for their life. Younger patients need a kidney that can last them a lot longer than an older patient is. You look at the time that they've been on dialysis, because the longer you've been on dialysis, the higher your chance of dying from kidney disease. We look at things like, the quality of each individual organ and then matching that with the recipient. You look at the sensitivity of that recipient to rejecting an organ. So there are many different complex algorithms that all go into place, but the ultimate goal of the folks that allocate the organs and set the rules, which is called UNOS, United Network for Organ Sharing, is to give the organs to the people who are most in need first.
Excellent. Thanks so much. Brother Likington, could you talk a little bit about how patients are evaluated for kidney transplant? What types of things do they need to do to undergo this evaluation? I think we may have lost Brother Likington for the moment. Brother Gilbert, could you hop into that question?
Sure, yeah. So I would say we talked a lot about receiving kidney transplants for patients who are on dialysis. I also want to point out that you can get a kidney transplant even prior to going on dialysis. So I would say the first step would be to speak with your kidney doctor about what is your number, what is your percentage of kidney function. If you have a percentage of kidney function of less than 20%, then you're actually eligible to get on the kidney transplant list before going on dialysis. And this is very important because if you get on a list earlier, you'll be able to start accruing time before going on dialysis, and you have the possibility that you may never have to go on dialysis. So I would say that's the first step. The second step will be talking with your nephrologist or whoever your physician is and asking them for a kidney transplant application. You can get started evaluation at one of the kidney transplant centers. We have about 4 kidney transplant centers in Houston. Once you send in that application, then the evaluation is started. The biggest part of the evaluation and the main part is we're basically trying to evaluate a patient to find out if there's any disorders, underlying disorders, which may cause a decrease in survival for this patient after they receive the transplant, or if there's any risk factors which would cause them to not have surgery in a safe manner. For example, if there's a patient with really severe heart disease and they're at risk of having events around the time of surgery, then that may be a patient that needs to undergo further evaluation, further treatment of their heart disease prior to getting on the table and getting a transplant. If someone has a severe chronic infection like tuberculosis, or if they have an active cancer, then those are patients that may not be eligible for a kidney transplant at this time, because some of the medications that we use after you receive a kidney transplant, medications to decrease your immune system and keep your body from rejecting the kidney, they can exacerbate cancer, they can exacerbate infections. So the cancer has to be treated, infections have to be treated in order for a person to be eligible. Another big one is some patients need weight loss, because we have studies showing that patients who are obese have more difficulty with surgery and sometimes wound healing problems. So weight loss is important. And I would say the final and one of the other most important factors that are evaluated is the heart. So you want to make sure that you have a strong heart going into any type of surgery, including kidney transplant. And if there are issues with the heart, as nephrologists and as transplant surgeons, we want to know about that so that we can know what to expect and have a heart doctor on board, cardiologist on board to help us if there are any complications. Much of the other parts of the evaluation are pretty straightforward. Of course, insurance verification, meeting with a dietitian, with a social worker, all of those things will occur as well. After the recipient has been deemed stable to be on the kidney transplant list, then they can start alerting friends, family members, other people about how to get in touch with the transplant center if they want to potentially donate a kidney.
I know that the senator needs to get back to the duties of the legislature. I just wanted to ask, are there any policies that we could do, make changes to, that would increase the opportunities for organ donation, Brother Miles?
Yeah, Brother Narcisse, there are some policy issues that we'll be adjusting, that I will be bringing forward here in the state of Texas. We need to talk to some of our federal brothers surgeons. We need to talk to some of our federal delegation brothers in the capital of the United States of America. But the simplest one, as we all know, I think everybody on this call already knows, is an opt-out program and not an opt-in program. Instead of an opt-in program, you know, required hospitals, and if we could require some hospitals to establish uniform, automatic electronic donor referral systems to refer all patients to deaths in relevant organ procurement organizations in a timely fashion, or to provide strong incentives to do so, Dr. Narcisse, we can do something in that nature. Currently, a number of different programs and tracking methods are used. The standardized system will allow donors to be identified and matched as fast as possible, and less people fall through the cracks. Another thing, which I think is where we're missing the mark from a policy situation, if we allow organs, older donors to be used on recipients who are comparable, like people of the same age. For example, 62% of the kidneys that are characterized as commonly as rejected in hospitals in the United States of America are accepted in the country of France. Okay? They're accepted. So if we can start matching and taking some of these requirements and doing the best. Look, when we want to do something in this country, when we want to find cures for things, we're able to do it. We got to we got to show people that we want to do it. And of course, awareness campaigns like what the brothers are doing tonight are very important. Campaigns at our church, Brother Gilbert, and other churches across our clergy. And I'm sure the same thing is going on in Memphis, brother. Did I hear you say you're in Tennessee? You're in Nashville. Is that right, Brother Lewis?
Yes, Nashville, Tennessee. Yes.
And we need some of those same kind of programs going in Nashville. But I'm going to be working with Dr. Narcisse in this next 88th legislative session in Texas to be bringing some things forward. I just spent the entire day, Dr. Narcisse, with the Commissioner of Health and Human Services, Commissioner Young, taking her to Harris Health, taking her to Legacy today, Brother Gilbert, Brother Cotton, and spending time with Brother Steve Williams, who's with the City Health Department. But there's so many things, when this country wants to do something, we can get it done. And that's in any industry, in any field. We just got to have that want. We're going to have to start putting pressure as we are leaders of Alpha Phi Alpha. We're going to start putting pressure on our brothers, first of all, in Congress and throughout the United States and these other capitals across this country. and we can get some policy on the books, Brother Narcisse, that will make a difference and stop making us as African American majority men, African American men, as being served up for dinner. Like what did you say, 17 times a day? Is that the number I heard you say, Dr. Narcisse, earlier?
17 people die every day waiting for a transplant.
17 people die a day waiting on a kidney transplant. We need to better those numbers, and I look forward to working with you.
Well, thank you. Appreciate your time, Senator Miles. I know that you needed to step out, but anytime you're able to join us in the future for conversations such as this, we always appreciate it.
I'm a phone call away, brother. I'll do anything for my doctor to save my life.
All right.
Brother,
thank you, sir.
Your brothers be good. Keep fighting.
You know, I work in a hospital as an internal medicine physician and hospitalist, and so I often take care of patients who are very, very ill. And one of the things I hear from people is that if I agree to donate my organs, the medical staff, the hospital staff won't work as hard to save my life. Brother Leckington, you're back. Thank you so much. Could you? No worries at all. Could you speak to that, to this myth?
I didn't get the last part of this.
That if I'm an organ donor, if I've signed up to be an organ donor, the hospital doctors, the hospital staff won't work as hard to save my life.
Oh no. I guess that's just kind of an urban myth. But our obligation, the reason why we're there is for the individual patient itself. We really don't have anything to do with the recipient of the organ. Our goal, our only goal, is for us to take care of the patient. And I understand there's a lot of insecurity about certain things, and a lot of myths that you hear, and I can assure people that's not the case. And in fact, if you think about it, there's so many redundancies in a hospital system where that's not even feasible, because even with each individual patient, you'll have a patient, a nurse assistant that would assist the patient, that they'll have two each day that evaluates the patient. Behind that, you'll have the nurse, each doing a 12-hour shift, and each one will be 2 of them seeing the patient. And each patient, particularly when they're in that point to where we're talking about organ donation, most of the time they're going to be intubated in the ICU, and you'll have a host of doctors there. So there's so many redundancies that's just not even feasible. But people that's taking care of the patient, the nurses, nurse techs, the docs, the only goal is for patients.
I often hear that people will say that organ donation is against my religion, and I can tell you that all the major religions are supportive of organ donation for their members. And so whether you're Roman Catholic myself or really any of the other faith backgrounds, that's not something that is a barrier to donation. Brother Cotton, I often will hear people will say that, maybe along the lines of the same thing that we talked about with Brother Leckington, sometimes I hear people will say that maybe I won't even be dead when they're here to take my organs, or that an open casket funeral won't be an option. Could you speak to that, Brother Cotton?
Absolutely. And a part of my job, when it comes to a transplant, a liver transplant or a kidney transplant, I would consider it as multiple operations all rolled into one. So first of all, big step back in terms of donation, you have an option for living donation for certain organs, and that includes kidneys, or you have an option for deceased donation. So for living donation, like in the kidney world, or removing a portion of a liver, you can take a living, healthy person that's been worked through to make sure that we're not going to hurt them with removing a portion of an organ, or if you have a pair of organs, a single organ in the kidney situation, and then that can be used for a recipient in the appropriate selected population. So that's one way that we do it. And again, the whole part of the donor evaluation in a living donor situation is making sure someone's not going to be hurt by taking out an organ. In fact, there's a totally different team of doctors, one that takes care of the recipients, one that takes care of the donors, to make sure there's no bias or conflict of interest. Now, when it comes to the deceased donors, the first operation that happens is a recovery from the deceased donor. What is a deceased donor? A deceased donor is a donor who looks alive because of life support. So they have a machine that's making them breathe. They have medication that's supporting their blood pressure, but they have been considered brain dead. Now, brain dead as a concept is very different than what you may see on TV. In a movie or something, you see somebody who's brain dead who wakes up. If we look at all of the states in the United States of America, if we look at this concept of brain death is equal to cardiac death, meaning once someone is brain dead, this is an irreversible condition where their brain can no longer tell their body to function appropriately. There is absolutely zero brain activity. And then when that happens, again, all of the other functions that appear to be normal are all because of artificial means. And so these are patients who are dead, and then dead donors are what we use for these organs. So when I perform deceased donor recoveries as a part of what I do, and part of when I come in, a whole nother team is taking care of this patient. I've never even met them alive. I've never even known about this person until brain death was declared. And I have to physically examine a piece of paper that says doctors have declared by multiple means that this patient is deceased. So a donor is not waking up. A donor is not moving. A donor is a dead person on whom we're doing a recovery. And again, there's a distinct separation. So a recovery team, a team that's taking care of a recipient, is not in play. In fact, a donor is not considered for donation until all of these things have been considered in their totality. So healthcare providers, healthcare organizations are obligated both by kind of your oath and by law to take care of someone to the fullest. So a brain dead donor is a deceased donor. This is someone who is not alive, who will not come back to life. They're not waking up. They are deceased. And in terms of what you can do at a funeral, all of the recovery surgeons are very cognizant of making incisions that are all very well hidden for any standard funeral. So, a shirt and tie, a blouse, etc. None of the scars from the recovery are going to be visible. A mortician can make a body look like it would in any other situation. So it does not preclude the ability to still celebrate the life of the donor.
Excellent. I've heard that only the rich and famous people go to the top of the list when they need an organ donated. Could any of you speak to this myth?
I can speak a little bit to it because we deal with it a lot in terms of how organs are allocated. And I look at every day when I'm on call, I'm looking at organ allocations. So in the United States of America, it's important for all of us to know that organ transplantation is very heavily regulated by the federal government. In fact, there are laws that tell you what you can and can't do, what hospitals can and can't do, what providers can and can't do. All of transplantation is regulated. And this has been since 1984. So there are rules on how organs are allocated, and there's a list that's generated by this group called the United Network of Organ Sharing for every single deceased donor in this country. Every single, in fact, living donors, all of it goes to this organization, which is going to create a match list, and it's all going to be in accordance with the allocation scheme for that organ. So you can't buy your way up, can't buy your way down. The list is the list, and we go through the list to transplant organs. Now, I do want to talk a little bit about access to transplantation because I'm able to see it in a lot of different ways. Many times in many private organizations, for many organs, the payer is important. And quite often the payer is private insurance. But if you look at kidney transplantation, the most common payer is Medicare. Medicare pays for dialysis service, pays for transplantation for everybody. So, this is, again, something that's a part of how people are funded. Children are funded by Medicaid pretty commonly for transplantation. And then if you are a veteran, and I know this pertains to many of our brothers, many of the people who are watching us today, every single veteran who has access to services through the VA has access to transplantation. So in the VA, there are separate transplant hospitals, and the veterans have access to it regardless of your ability to pay. Regardless of your resources, you have access to transplantation, which I believe is a huge underutilized resource. So I just wanted to put that out there for everyone to know kind of how this works. But you can't buy an organ. In fact, if you try to buy an organ from me, it sounds like a great idea. The next day I'll go to jail. So you can't do that.
Yeah, and I like to just real quick to kind of piggyback off of what Dr. Cotton said. I think that is a big misconception. And I remember about 12 years ago when I first started as a nephrologist, I had a patient, African American woman, and I was talking to her on dialysis about why she should get on the kidney transplant list. And one of the things she said was, why should I spend all that time trying to get on the transplant list when only white people are getting the kidneys anyway? So there was a misconception on her part that there was something, going on where only a certain group of people were receiving kidneys. So I explained to her about the process, kind of what Dr. Cotton just said. But I do believe that one of the reasons why she had that misconception is because what she was seeing, it seemed like there were more people of different races getting transplant in the unit, and part of that was because there was a decrease in the amount of living donors that were coming to African Americans. So that's kind of a little bit of a different issue, but I think it is something we should address. Is that our rates of living donations are about 16%, whereas white people is about twice that, about 33% are of living donations. And I think that has to do somewhat with miseducation as far as transplant, and also some mistrust of the health community.
Thank you, Brother Gilbert, for that. I think it is fair to say that persons of color are more likely to need a new organ. Hispanic Americans are 1.5 times more likely to have kidney failure than others. African Americans 3 times as likely to have kidney failures. Native Americans 4 times as likely. For other organs, Asian Americans are 4 times as likely to have hepatocellular carcinoma, which can be treated by liver transplantation. So there are some differences in the need. And I think that there are some concerns that people have had when they look at the data, that there's a shorter waiting list for those who are Caucasian, about 295 days in one study, compared to those who are African Americans, who were 53 days. So I think that it's a complicated topic, and the amount of living donors is something that's an important part of that conversation. But I think that individuals do see that disparity. I just before we run out of time, I do want to bring up one thing. How can one donate? Could any of you guys talk about the steps that you might take with organ donor?
Yes. Well, one of the steps I will always go through is just I try to first just talk a little bit about that. Once you donate say your kidneys, then the information I'm getting is that you will be taken care of, on your side too. Also, I'm going through Vanderbilt Hospital here and Vanderbilt University Hospital here in Nashville, Tennessee, and Ascension St. Thomas, and both of them, both transplant lists have steadfastly told me that the donor will be taken care of for a long time too. The donor will be the kidney donor will have significant care through the hospital, for their part also for being a donor. So the next step there is just to provide the phone numbers and provide the websites, and just ask them to give them a call and explain to them that they would have to go through a medical evaluation to make sure that they are medically cleared to become a donor. Okay, the patient has to be healthy and has to have no underlying conditions that may preclude him from being a donor also. So that's the next step right there. And once they go through, once they go through that evaluation, it's either a yes or a no. And I never hear about that, but I've already steered 3 or 4 of my family members to get these particular evaluations, and of course, a couple of them didn't pass and things like that. But everybody, I have some family members that are up for trying to get evaluated, but that's one of the first steps is to get a medical evaluation to make sure that the donor is healthy also. That's the first
Now,
step.
and I think one thing that's important to clarify, thank you, thank you, Brother Lewis, is Brother Lewis is talking about the process for evaluation for living kidney donation. So
Yes.
when we're talking about living kidney donors, you're talking about giving a kidney usually to a particular recipient. You also have the option of being what's called an altruistic donor, where you are giving a kidney to anyone on a particular hospital's waiting list who needs an organ. That process, again, evaluating a living person for an immediate need for donation of an organ to another person. And again,
Yes.
that's all about making sure that that donor is safe to give, in this case, a kidney, in other cases, maybe a portion of a liver to a recipient. Now, there's a whole nother process for being a deceased donor in this country. So remember, deceased donor means you're dead, so you can't give your consent after you're dead. What instead we're talking about is how do people make clear their wish towards organ donation? And it can happen in a few different ways, and the laws are a little bit different in each state in terms of how you register. But most states have an organ donor registry where an individual can give first person consent, meaning me, Ronald Cotton, I can decide I want to be an organ donor, so I can sign up to be a donor. In Texas, it is donate Texas, where you can make a decision to donate your organs. You also have the option when you are for us, the DPS, and you were getting a driver's license to declare whether or not you want to be an organ donor. So that first person consent is the most important thing if you desire, again, to donate your organs after your death. Now, the other thing that is important is to discuss this decision with one's family, because the first person consent is always something that will let someone be a donor, but also the organ procurement organizations, who are the people that work with donor families, seek consent and input from the donor family. So the one who survives you, your next of kin, it's very important that they are aware of your wishes at the same time. That can create difficult conversations, especially because of the myths that are often associated with organ donation. But I believe it also presents an opportunity for education and for further, spreading the word of what organ donation is and what it entails. Dr. Narcisse hit the nail on the head when we talk about the disproportionate representation of underrepresented minorities in certain disease processes that lead towards transplantation. If you look at the African American population, and you look at how many African Americans there are in the United States of America versus how many are affected by end-stage renal disease, it is staggering. And if you look at the ages where people are affected, it is staggering. And we have an increased need for this life-saving modality. And I think that, implores to us that not only do we have to consider donation to help ourselves, but in addition, we have to be advocates for ourselves in healthcare situations, healthcare organizations that sometimes do not have our best interests at heart. Healthcare disparities are real. I'm a practitioner every day, but I also believe that we can make an impact and take care of ourselves and our communities better. And I think the first thing is to empower yourself with knowledge and empower yourself with your provider and to seek actively the best care and definitive care. And so that's my 2 cents that I wanted to talk about. I see we have Donate Life Texas written up there, but that's how you would become a deceased, consent to be a deceased donor.
Is there any a need to match the ethnicity of a donor to a recipient?
No, so you don't have. Well, I'll do a caveat there. So for many organs, including livers, and you don't have to match every single element of what's on a cell with what's in your body. So your body's programmed really, really well to understand what is from you and what's not from you. And things that aren't from you and that get into your bloodstream, your body is programmed to kill it off, whether it's an infection, whether it's a virus, whether it's a cancer, whether it's a cell of your own body infected by a virus or cancer. It's programmed to recognize that and fight it off. Well, your body knows when something didn't come from you, and it recognizes it in a lot of different ways. We think about blood groups. You have to always match a blood group with organ transplantation, but many organs, you don't have to do much more matching than that. Now, when we look at kidney transplantation, it's a little bit more in depth when you look at things that are on the surface of the cells with how things match up, and that there are potentially, if certain fingerprints that certain groups have in common, and so it may increase the rate at which they're compatible, but it's not an absolute requirement that you have to get an organ from someone of your exact same. I won't use the term race since that's artificial, but ethnicity. When we look at race, that's an artificial thing, right? It's not based in science, but you don't have to share genetic background to be a recipient from a particular donor.
it seems that there are differences in the willingness to provide donation. And one of the things that we often see in our hospital is that individuals who've had a less comfortable experience with the healthcare system are less likely to donate, and that's often individuals of color. Um, Similarly, there have been studies that have looked at the amount of time the organ donation procurement organizations have spent with families, and if there's not as much time spent with a given family, they may be less likely to donate. And so we certainly encourage the organ procurement organizations to really pay time and attention to all the potential donors, which speaking of deceased donors specifically. Um, and again, to share how important the need is to donate organs in community, because African American people are often unaware of the need. They're concerned about the religious myths that we talked about before. There's a deep-seated distrust of healthcare that goes all the way back to the Tuskegee syphilis experiment. And I think that there are a lot of things that we can do as a healthcare organization to try to increase the awareness and increase the donations, because if we can increase donations, we can potentially save lives. That's what it really comes down to, trying to save lives. And so programs that increase this awareness in the community, that spends more time, specific targeting of communities that have not historically donated at such a high level, will increase the number of donations from those communities and save lives of the members of those communities. And that's something that I'm a huge proponent of. I heard you talk about registering at the state donor registry. You talked about designating the choice on your driver's license, which is the way we do it in Texas. You talked about telling your family. I can't emphasize that enough. Talking to your family. The other thing I would emphasize to individuals is making sure that when you're making insurance and healthcare purchases, that your insurance covers donation, that covers transplantation. We certainly would not want to be in a situation where you need an organ, need a transplant, and you don't have the appropriate resources. Dr. Cotton mentioned so eloquently so many different ways where you can achieve these resources, but there's still individuals who don't have access, and we want to increase that. I'd love to go around the panel and try to get a sense of last thoughts. Brother Leggington, I'd like to start with you.
I mean, I think for us, seeing Brother Cotton and Brother Gilbert, I think it heartens me, because many times in our community, there is a distrust, but when you see people that look like you feel a little bit more comfortable and can be more honest and open. And I think that makes a big difference. But I think the most important thing we can do is just have conversations with patients. And one thing I will say, Brother Lewis, healthcare is a private matter, but as far as kidney donation, transplantation, I think this is the time where I encourage my patients. This is the one instance where I respect your privacy, but I would reach out. You could talk to your church, neighbors, whoever. Let everyone know. I mean, that what you're going through and what you need, because you'd be surprised. A lot of people may be willing to donate. So again, healthcare is a private thing, but when it comes to transplantation, there are a lot of good Samaritans out there, and you'd be surprised who will be willing to put their name on the list to help you out.
Brother Gilbert?
Yeah, I agree with that completely. First of all, this is a great discussion. I hope it's well received. I'm glad that we had such input from the people on the panel. I agree with Brother Leggington that in this situation, we're trying to be on the kidney transplant list, trying to receive a living donor. You'd be very surprised. I have had patients that put on Facebook that they were in need of a kidney, and they had an altruistic donor, to someone that didn't know them at all, to donate a kidney, or someone who had a church member who didn't know the person that needed the kidney, but they had a cousin, that passed away in a car accident. That's another way that you can direct, as a deceased donor. You can direct an organ, for example, from one of your family members to someone else's family or friend of the family. And that's something that would happen when the organ transplant network comes to the bedside. When you have a family member that is passing away, they may ask you, is there a person that you want to direct this kidney or these organs to? And so that can be an opportunity for someone to donate a kidney that doesn't even know the person that is going to be receiving it. Um, I think that what Dr. Leggington said also is true in that it really helps not only for us to give education to patients, but if they see, when they come in the operating room and they see, Dr. Cotton sitting there and he's a, African American male, he's going to operate on them. They really feel very comfortable about that and are able to move forward. So we do need to try to increase our representation of physicians, and hopefully we get more nephrologists, we get more transplant surgeons that look like us. As for the other people who are watching this, who may not be patients with kidney disease or may not need a kidney transplant, you can still help. So you can help by making sure that you're listed for a kidney transplant. And if you have a family member who is on dialysis or who has kidney disease and they're not, on the transplant list, you can talk to them about some of the things we talked about, how it will increase their life and increase their quality of life to be on the kidney transplant list. Thank you guys again for your time.
Brother Cotton, we'll have to unmute.
That's like the phrase for the 2020s, I guess. But I tell you, it's inspirational for me to see Dr. Leggington, Dr. Gilbert here today, Dr. Narcisse, who's been a mentor of mine for a very long time. Thank you for inviting me to be here. Brother Lewis, hearing your story is quite inspirational to me. Two things I want to say real quickly to this group and to everyone who's assembled here. I just want to tell quickly my story to transplant. I did not consider transplant as a surgical career initially. In fact, I wasn't looking forward to doing a transplant rotation. I thought it was going to be long hours, and I just wasn't into it. And I got there and was immediately engaged in this amazingly transformative, restorative experience that from something really bad happening to a donor that was beyond our control, you have a recipient who is dying and they can be restored and they can be made whole. And to participate in that, to be a part of this extraordinary journey is humbling. So the amazing part of transplantation is this amazing team sport. And any one of us can be a part of that by agreeing to be considered for deceased donor organ transplant, for deceased donor, by consenting to that, you have the potential to become a hero and transform someone's life. That's extraordinary. And then the other thing I would encourage is for anyone who is listening here and who's considering their careers, and for young brothers in Alpha, or young people otherwise, or people who are not so young, consider the impact that you can make on one's life as a healthcare provider. I believe the relationships that we have with our patients is extraordinary. And Dr. Gilbert hit the nail on the head. When I walk in and somebody's afraid and they're about to get a transplant and they're about to be cut and they don't understand what's going to happen, they've talked about it, but they don't know what it means. When you see someone that looks like you and that shares your beliefs and shares your background and shares your experiences, you can look at each other and immediately there's a comfort and a relief that can come from that. And there's a trust that can come from that as well. And that trust can transcend decades and if not centuries of disenfranchisement and distrust. So for people who are here and considering healthcare, hate to get on that hat, working admissions in the medical school to healthcare is a noble field and you can impact lives in a very big degree. So thank you for letting me talk today. I know I talked a whole lot. I appreciate y'all giving me the space to do that. And that's all I got.
But Brother Cotton is one of, I don't know, 20, 30 African-American male transplant surgeons in the country. There can't be that many. And so we're blessed in the Houston space. Here at Houston Methodist, we're blessed to have Constance Mobley, who's an African-American female physician, and she was instrumental in guiding some of the conversation this evening. I wanted to give credit to her. Brother Lewis, we're here because you reached out and yes. we heard your story and we heard your experience. I'd love to hear your final thoughts.
Well, this is all about education to me. This is all about making sure that you learn everything you need to learn about transplants and learn everything and figure out everything you need to know about your particular situation. And when this hit me, when I was told that my kidneys were failing, I learned and I tried to learn everything I could about it. And also, I tried to myself dispel all of these myths and all of these fears from past. Okay. And I just said to myself, I was not going to listen to those myths. And I also said to myself, I'm going to be an advocate for myself. I'm going to make sure that I'm going to get the best health care that I can. I'm going to ask the right questions from my doctors and from my nurses and from all the people that I've come and met in this journey here. As far as everybody at the Kidney Transplant Center, all the doctors and nurses that I met at Vanderbilt, and all the doctors I met at Central St. Thomas, all the doctors and the nurses that I go to every week for all of my doctor's appointments and things like that for blood work, everything. I ask questions, I drink in all of that knowledge, and I just, have all that knowledge, and I make good decisions based on that knowledge. And education, the knowledge is the best thing to do because you dispel all these myths, you get rid of all these myths, and you get right to the truth. And the truth is that you can get through this, and you can survive this, and you can make it to where you can get. I'm waiting for that transplant. I'm waiting patiently for that transplant, but I'm not giving up either. I have a positive attitude, and I'm going to keep a positive attitude, and I'm going to ask the right questions and make sure that I'm here every day because you also have to set yourself a goal, okay? And sometimes you have to set yourself an impossible goal. And my impossible goal is I want to see my grandkid become a grandfather himself. And that's an impossible goal, but I'm going to set that goal. And that's one of them goals that's going to keep me living. And that's one of the goals that's going to keep me going and going until I get this transplant and after I get that transplant. And I'm not going to give up. I'm going to keep a positive attitude. And I'm asking everybody and anybody, and that's how this has started. I wanted to get all of this into the Sphinx under health, and I haven't seen it in the Sphinx yet, but that's where it started. I'm asking everybody, and I'm getting over that fear too. Okay, you have to get over your fears. You have to get over your fears. You have to get over your fears every day. Ask, ask, ask. That's what they tell us every day. Be the ask. Ask anybody and everybody you know, and don't be afraid when somebody says no. Just go on to the next person, and that's all I can do. That's all I can do. That's all I can do. But I'm not going to give up. Okay, I'm not going to give up and be in positive attitude. I have a positive attitude. And the last thing is, we have to talk to our kids and our grandkids about this also. We have to make sure our kids understand that this is what life is all about. I talked to my grandkid about this too, and he understands, and he's okay, but he also understand that this is what life is about also too. I mean, everybody's human, okay? We're all human. We're mortals, and we're gonna live and we're gonna die. We're gonna live and live our lives, and then one of these days, it's gonna be our time. But you just have to understand that that's what life is all about. And there's no you can't sugarcoat anything. You can't try to hide anything. Just put it all out there and let the cards fall where they may. So,
Brother Lewis, what a powerful statement. Your testimonial is what inspires us. We live in an environment where we live by PowerPoint presentations and academic discussions. And when we hear your words, it reminds us exactly why we got into medicine in the first place.
yes.
I've had an opportunity to be blessed to watch the development of Brother Billy Gilbert, of Brother Robert Leggington, of Brother Ronald Cotton, and it is awe-inspiring. I wish I could be as good as these brothers that you see before us. Brother Miles, who had to step away, we appreciate him and his contributions to this discussion, his voice, and I've challenged him to be an advocate for organ donation in the community and in the legislature. Brother Lewis, again, thank you so much. I thank all of you for taking so much of your time. I spent hours and hours and sleepless nights of trying to decide what could I possibly contribute to this conversation, and I should have just known. I just needed to call you all, and it all would be taken care of, and I didn't need to lose all those sleepless nights. Our next Facebook Live presentation for the Surgeon General Initiative is going to be on dental health, and that's going to be on May the 26th. Again, same time, 6 o'clock Central Time. We'd love to have your participation. Please, if you have questions, we'll be monitoring the chat even after the presentations are completed. Please contribute your thoughts there. Please contribute your ideas. We had tonight's conversations because somebody brought the topic to us. We continue to look forward to those opportunities. I'd like to thank General President Brother Lonzer for giving us the opportunity and the space for this presentation. It's the brainchild of Brother Sterling that started our conversation tonight, and I want to thank him as well. Thank each of you for taking your time to participate. Without your participation in the community and the audience, we would not have a reason to be here tonight. So I wish to thank all of you. Wish you my prayers, blessings, and great health. Good night.